Years after surviving 2 major heart issues, the man you're about to meet got a devastating blow. How he went from making end-of-life plans to fulfilling his lifelong dreams, thanks to his cardiologist right here at the health system.
From the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Let's get straight to today's guest. After recovering from back-to-back heart scares, the man you're about to meet still felt off. He just knew something wasn't right. Thankfully, he listened to that gut instinct.
There is something they can do for total occlusive disease, and that needs to be common knowledge.
One of the best parts of interviewing Dr. Michael Kennedy, who practiced medicine for decades before becoming a professor here at KU Med, is when you ask a question, Dr. Kennedy makes sure you understand the answer. How would you explain to someone like me without any medical degree, what did they do to fix your heart?
So, you know me, the teacher, I want to draw a heart.
You can draw.
The heart has a big pumping chamber called the LV, and then the right ventricle.
But before we get to the solution he's so happy about, we need to go through one of the saddest moments of Dr. Kennedy's life.
It was kind of dismal, you know. It was a depressing appointment. Sorry, I don't mean to get emotional, but it was essentially kind of a downward progress, kind of get your affairs in order.
It was August of 2022, 18 months after Dr. Kennedy had survived a heart attack and triple bypass surgery, and he had gone back to the doctor. After a stress test and heart catheterization, doctors discovered something, and it wasn't good. A chronic total occlusion, also known as a CTO. Plaque had built up, causing a total blockage in his coronary artery. Dr. Kennedy and his wife were reeling. Having just retired from practicing medicine, he was ready for his next adventure, which included teaching medicine, spending time with his huge family, and traveling with his beloved wife.
My wife and I were high school sweethearts.
And now this? How could it end this way? A few days later, the phone rang. It was his doctor again, who had spoken to another doctor who happens to specialize in treating CTOs.
He reviewed your case and he thinks he can help. So I was, you know, the emotional roller coaster.
And that's how Dr. Michael Kennedy came to see the University of Kansas Health System cardiologist, Dr. Tony Spaedy. And Dr. Spaedy could not have been more reassuring and comforting.
It didn't take a minute to say, this is a no-brainer. So he did a balloon procedure. And so in order to do that, you have to be able to pass a wire through the blocked area.
An hour after the procedure,
I was ready to leave right then.
They made him stay the night, but Dr. Kennedy was a new person. And that next morning, he walked out of the hospital and into those next adventures he'd been dreaming of having. We are so happy and pleased to welcome Dr. Michael Kennedy to today's program, along with his amazing cardiologist, Dr. Tony Spaedy. Thank you so much for being here. Dr. Kennedy, right out of the gate, how are you feeling today?
$1 million bucks. It is night and day difference. You know, a year ago, before the procedure, I was, you know, had no energy. Every time I walked, I didn't realize I was having some chest pain because it wasn't typical. It was between my shoulder blades, and now I haven't had any of that. I've been walking on a regular basis. We've made 6 trips around the country. I just really feel normal, but that's such a huge relief. It's
Yeah.
extraordinary.
It'll be 1 year on December 1st,
Yeah.
since Dr. Spaedy performed the procedure. I want to get right back to something you said. You didn't notice chest pains because they were between your shoulder blades,
Right.
and you're a doctor.
Right.
So it must be tough for people who aren't doctors to recognize those. So my question was, you noticed something was off, but even your medical training couldn't quite help you pinpoint what it was?
Well, there's so much. Fatigue is one of those diagnoses that you kind of dread when someone comes into the clinic and they say, I just don't know, I'm just kind of fatigued. And then the list of possibilities is expansive. In my particular situation, I have diabetes and I have high blood pressure. And so, or I did, because all those things they're all under control now. But I didn't have the typical symptoms of this mid-sternal crushing chest pain, like someone's sitting on my chest.
Right.
Instead, my pain was not the normal, probably because of the diabetes.
Okay.
And so my pain was between my shoulder blades. But on the other hand, that's exactly why we teach young physicians of today to not rely on typical pain, to look at the whole picture and do they have pain that of any kind that comes with exertion, goes away with rest, and then can you relate those symptoms to something like like heart pain?
You're such a good teacher because you were able to explain the procedure even to me, and I'm not a doctor. I want to ask you more about that procedure and also Dr. Spaedy, because you were awake, Dr. Kennedy, for the whole heart procedure.
Yeah.
Why is that? Because it's not the norm, right?
Well, I'm just kind of this
You're allergic to something, right?
I'm allergic to the medicine they typically use for sedation. That group of medicines are called benzodiazepines.
Uh-huh.
The typical one is Versed, but I don't have an allergy. I just don't metabolize those like others, and it's a genetic thing. And there's a certain percent of the population that has or lacks that gene. We're called slow metabolizers. But for me, it puts me to sleep for a couple of days.
Oh wow!
Yeah,
that can't be good.
And
Right.
so I requested to not have that medicine. And after a conversation with Dr. Spaedy, I was like, so, how much discomfort can I expect? And he goes, I think after we get the lines in, I don't think you should really have any. So it's just a matter of can you lay still or will you be anxious through the procedure? And I was like, no, I think I'll be okay.
Dr. Spaedy, how many patients have you had where you've performed heart procedures and they can't be sedated for it?
So usually those are people that are just really sick, like we're worried about their breathing, so
Right.
we try to really minimize how much we sedate them because we don't want them to get worse while we're working.
Was it weird to have your patient awake and talking to you through this heart procedure?
Not really. I mean, we've done, I've had known cardiologists in the past that just don't use it, period, for any procedure. So you can do that. There's no danger in not giving sedation. But usually it just helps everyone if the patient's just a little bit relaxed, and they're less likely to be up looking around or scratching their face or whatever while you're working. So it kind of helps everybody just to take the edge off, just to mild them out. We usually don't put them asleep though. They're usually awake, just sedate. We call it conscious sedation. They're awake, but they're just sedated mildly.
Was Dr. Kennedy asking you doctor questions, like procedural questions as this is going on?
I tried to minimize that. I was
Okay.
like, I want this guy to concentrate.
Okay.
Can you turn the screen this way a little bit?
You didn't do that? Did you do that?
I asked what they, before the procedure started, and the scrub nurse was like, nah, we don't usually do that.
Right, just lay
Like,
still.
okay, all right.
Let's keep this chatting to a minimum.
Yeah.
When it comes to the specific problem that Dr. Kennedy had, he had a total blockage in his coronary artery. How does someone function with a total blockage?
So it's amazing. The heart's pretty amazing. It typically grows what we call feeders or collaterals. So if you have 100% blockage, one of the other arteries tends to grow some blood flow to help that territory. We actually saw a young guy, I was just telling Dr. Kennedy last week, he's 45 and all 3 of his main arteries were occluded. And you would think that's not compatible with life, but he had enough collaterals growing from everywhere that it kept him going. So it's pretty amazing sometimes.
The body will find other little tributaries to work through?
They can grow fairly fast. Some of them are probably there in a microscopic level or very tiny, tiny vessels, but they'll enlarge, they'll expand and dilate and then provide more flow. Not ideal flow, but enough to keep that muscle from dying, so keep it alive.
I want to share an image with our viewers. It's a picture of that blockage of the artery before you opened it up. So we have it behind us, Dr. Spaedy. What are the arrows at the top showing?
Yeah, so the 2 arrows at the top are showing some severe disease in the vessel. This is his main artery down the front of his heart. Up here is the top of the artery, or we call it the proximal part of the artery. There's severe blockage and plaque in there. It should be wide and fat and smooth through there. And then this lower arrow, there's a little stump where it's stumped off. You see a tiny, that actually the branch looks big. It's gotten bigger to help provide some flow around it. But that branch should be smaller usually. And then this should be a main artery going right down where the stump is.
Okay, so it's all kind of jaggedy up there and then just ends right there. We have another image to show you. This is after you opened up his artery, which that looks so much different compared to image number 1.
Yeah, so we stent up here, but we also were able to get through this 100% blockage. And then that little branch that we talked about that looked bigger than it should be, it now looks quite small compared to the way the real artery is and the way the branch should look. So now the flow is going down the normal way, and that's why you're feeling better.
Yeah.
Is it rare that someone keeps functioning as long as Dr. Kennedy did with a total blockage? Like, what are the risks that come for the typical person who has this in their body?
Yeah, so everybody's different. So some people can tolerate it very well, and some people tolerate it very poorly. So the heart muscle is a big predictor of how much trouble you're going to have. If it's really injured your heart muscle, then you're more likely to have trouble. You know, if you have a weakened heart muscle compared to a strong heart muscle. And then it's interesting, so you can have the same blockage in one person, they'll have a lot of symptoms, another person may not have any symptoms.
If they don't have any symptoms, is it like a ticking time bomb?
Not necessarily. So a lot of people say, hey, is it even safe for me to go home? I have 100% blockage. Well, the good news is it's not going to get any worse. You know, it's 100%.
Right.
So
well, yeah.
It's not, so you've already got feeders, and actually exercise, things like that, getting out walking a lot, which you're doing, helps build more collaterals, more feeders. You know, it helps those little vessels if you do have a severe blockage. It helps grow more.
So your prescription wouldn't be bed rest if someone comes in for a
the old
CTO.
Prescription used to be bed rest, and we learned that's kind of the wrong thing to do. And
right.
The best thing is to actually get out and walk. You know, pay attention to your symptoms. So, you know, don't just ignore them. But you may have to stop if you're having significant symptoms. But if you can do it, if you can build your exercise tolerance, it's really good for the heart.
Boy, you're probably the 10th doctor we've had in just the past couple of months who prescribes exercise to help all sorts of major medical problems. Exercise as medicine can really make a difference.
Absolutely.
Dr. Kennedy had a triple bypass surgery just before this happened. So you'd already been through the ringer. You'd had quite a few scares. But how does a total blockage happen so soon after a triple bypass?
So it does sound counterintuitive, but a certain percent of bypasses will close in the first year. You know, typically you hear of bypasses closing years out, like 10 years out from, you know, their bypasses, commonly the veins from the legs don't last as long as the mammary artery. The mammary artery typically lasts you your whole life. Yeah. And the mammary artery sometimes won't take. And so it is probably at least 10% of the individual bypass grafts will close in the first year. And sometimes, a lot of times, they're to a little vessel that isn't that important, and the patient doesn't have any trouble from it. But occasionally, it's the main artery, and you can have significantly more symptoms.
When it comes to the recovery, Dr. Kennedy, you were saying you wanted to leave that day. I mean, you hadn't been sedated, so you were ready to go. That's a very quick recovery. How quickly before you were back on your feet doing things around the house? I know you've been working on this big house project and you've been up on your roof, and how soon before you could do that?
It was about a week.
A week?
Yeah,
Wow.
We started walking the next day. And of course, since I had been kind of limited, we were only able to walk, actually a few blocks the first day, and then the next day we doubled that, and the next day we doubled it again. But got to a mile and a half, and in that week's time,
Wow.
and then we just kind of slowly built up to there. I'm walking 3 miles a day now, and feel great. That's the biggest difference, is that before, to even get a half mile to a mile was such a struggle, and I had to stop frequently. We would walk a block maybe at a slow pace and then have to stop and rest. But now I don't break stride going up a hill. I don't have to
So cool.
stop. Yeah, it's amazing.
When
It's so great.
When Dr. Kennedy came in, we were so happy to see him, and I said, "Oh, how are you doing?" He said, "I was up spatuling." You were spatuling your ceiling, and you really are a warrior when it comes to home improvements. You're doing it all.
It's kind of funny because we tell people we're remodeling our house, and they go, "Oh, that's such a huge mess, and those people in your house all the time," and I said, "No, actually, my wife and I are doing the work." But we are taking down the ceilings. Fortunately, we looked it up, no asbestos, so we didn't have to worry about that. But then we had those acoustic ceilings, so we're taking all that down. We're minor shifting, replacing all the doors, taking out the carpets, nailing down hardwood floors.
We have some work at our house. Can you come hang out with us? Because we're not very handy.
So
we need some work.
We're probably 3/4 done at this point with the entire house.
And all this for a patient who was making end of life, getting his affairs in order. That's just such a huge difference. Dr. Spaedy, how long have you been specializing in treating CTOs?
So we started doing them in 2012, and really that was, I started doing interventions, got out of training and started doing this in 1994, but in 2012, or 2011 maybe, they came out with some new devices that were smaller, that allowed us to, navigate tougher areas.
What you did to Dr. Kennedy?
Right. So yours was maybe more of a standard, just go down the front of the artery to get to the blockage. But they've also come out with several things that, improved wires that let us get through the blockage, improved catheters that let us get through the blockage. Sometimes we'll even go down another artery and go through those tiny collaterals and go back up the artery that's blocked in a kind of a backdoor fashion. And so a lot of that equipment was advanced quite a bit, around 2011, and so in 2012, a friend here in Kansas City that does a lot of this helped us get started.
It's amazing.
I want to say too that I was surprised that they could go through your wrist, through the artery in your wrist to do this procedure.
And that's what Dr. Spaedy did with you? He went through your wrist?
And because, the usual is to go through the big artery in your leg in the groin area. And oh my gosh, that you had to lay there for 6 hours after a procedure like that to not move your leg. Of course, they have some new things now that they can shorten that time. But it seemed like it was a little bit longer to recover from that. It was longer to recover from that. And then this thing through the wrist kind of astounded me that was a possibility. And so I think that awareness by by both doctors and the public is a great thing to know that this really minimizes your downtime.
It's incredible. And I want to share something with everyone. Something Dr. Kennedy said about you, Dr. Spaedy, that really stood out to our team here.
I mean, it really is somebody who saved your life.
now I can, enjoy my grandkids, and I have 7 grandkids. So my wife and I are high school sweethearts. So we've been married 47 years,
Yeah.
right? So I get that back.
48.
It's crazy. It's crazy. It's overwhelming.
You just had an anniversary, by the way. You wanted us to correct that.
Yeah,
48.
so we're 48, and we just went to our 50th high school reunion.
Oh my gosh.
And went back to at Topeka High School, and we went to the library where we had met, and it was just like,
So
really
sweet.
kind of full circle moment, yeah.
What's it like to sit next to someone knowing you gave him that gift?
Oh my gosh.
Yeah, I think it's definitely gratifying. It's a big part of the job. The one nice thing about medicine, there's a lot of, you can talk about it whether it's a good thing or not, as far as being the person doing the job, but there's a lot of positive feedback, and you have kids that went into medicine, to my wife's surprise. So I think they see you work hard, but they also see some of the positive sides too, and that's definitely the most important side, is how the patient does.
So your grown kids have been motivated to go into medicine too?
Yeah, I have 4 kids, and they all went into it.
Oh,
so a
wow.
little bit strange.
Are they all cardiologists?
Nobody went into cardiology.
Do
they all
know
did different things.
What are their specialties? I'm just curious.
So one's a pediatric hospitalist here in Kansas City, Children's, and then one is applying right now. She's an internist, just finishing. She's a chief resident at Tulane, and she's applying to be a pulmonary critical care specialist. She's hoping maybe to go to KU. And then I have one who's finishing his child and adolescent psychiatry fellowship, so he'll be a psychiatrist. And then the last one's just finishing med school, but hoping to be a OBGYN.
That's the family you want at the family picnic. If anything goes down, you want the Spaedy family there. We have a lot of questions coming in already, and we'd love it if you send us questions for our patient, Dr. Kennedy, or Dr. Spaedy. Be sure to send them to us on all these different platforms. We're on YouTube, Facebook, the X platform, or you can email us at the All Things Heart email. We have all those links where you can connect with us in real time right there on your screen. So let's get right to it, because Jeremy Yenser has a question, and Dr. Spaedy, you touched on this. He wants to know about any advancements that have been made making it easier to treat this, where in other cases in years past it might have been difficult or even impossible to treat.
Yeah, there's been a lot. So it's amazing. It's the field is moving every year. So we're getting new devices and new techniques. So the other thing is there's a few guys. One of them's a couple of them were over at St. Luke's, and one's still there, Dr. Grantham, that have really advanced the process. And then also there's a guy out in Seattle that Dr. Lombardi, they've really been major leaders. They come up with all these new ideas, new techniques, things that people thought you couldn't do, then all of a sudden they do it a few times and it works. So yeah, I would say we have a major meeting on this every year in February, and always there's something substantial that's new, a new catheter, new wire, new technique.
That makes it possible for Dr. Kennedy.
So the field is still really moving. So when we started 10, 12 years ago with doing these kind of blockages, it's really changed.
Yen Liang has a question. Yen writes, if a myocardial infarction is left untreated for too long, is there a possibility it could lead to the rupture of the heart? For our viewers who aren't in med school, can you explain what a myocardial infarction is?
Yeah, so that's an interesting question. So definitely the myocardial infarction is when you hear somebody say they had a heart attack.
Okay.
And it's just, that's basically the lay term for type of injury to your heart. Something was injured enough that you lost a little bit of muscle. It can be a tiny bit of muscle that doesn't make much difference, or it can be a large amount of muscle. And to the second part of the question, could you wait too long where too much damage is done and then rupture the heart? And so occasionally the muscle will, from a heart attack, it'll necrose, or it'll basically die. And the muscle, instead of being firm muscle, it'll become very soft, and then it can actually tear because it's a high pressure structure. There's a lot of pressure.
Okay.
So it can either tear and the blood can go into the chest, or they can tear and go from one chamber to another chamber. It's very uncommon for that to happen, for the heart to rupture. Very, very uncommon. But if it's going to happen, it typically happens in people that had a heart attack that wasn't treated. They waited too long with the blockage occluded.
If the heart tears, how do you put that back together?
So that has a really bad outlook. You know, if it gets to the point where it tears, the surgeons still will frequently, you know, if they're a candidate, will still take them urgently to surgery. So if it tears, it's usually an emergency and they have to go fairly soon. But sometimes they can't. You know, it's either too much damage, the heart's too soft, you know, the stitches won't hold, whatever. There's different things that make that very challenging. Luckily, it's very uncommon nowadays because most people are treated. Most people,
they come right away.
They come a lot quicker than they used to.
Ruth Ellen has a question about recognizing pain, and Dr. Kennedy talked about how he was feeling something in his back, but it wasn't a crushing chest pain. Ruth Ellen writes, recognizing pain is an interesting topic. I have psoriatic arthritis, and sometimes I have symptoms, and I wonder if it's the arthritis or something else. How do you know if it's the arthritis or something else?
So,
doctor, who wants to weigh in?
So, you know, you can have arthritic pain in your chest, right? And you can have gastrointestinal stomach pain due to reflux disease. You can have pain in your chest. You can have lung pain in your chest. I think one of the key characteristics is pain that comes with exercise and goes away with rest. So if you're exercising and you have pain symptoms, and it can be jaw, neck, arms, either arm. In women, it tends to be a little different in its presentation. The classic description of that squeezed fist over your chest, that was even described as Levine sign, and but that turns out that's actually not a common presentation. It was just classically described in the old.
That's what we see in cartoons or in, you know, the person clutching their chest and.
Yeah, and so, but I think one of the key, and you can certainly fill this in, Dr. Spaedy, but I think one of the keys is that if you have pain that comes on with some sort of exertion, or like if your blood pressure's running too high, or those kinds of things, but then when you rest, that pain pretty much goes away, then you can relate that more commonly to cardiac pain. Now, sometimes if you have a history of that, and then you get pain and it doesn't go away even when you're resting, well, that's when you're calling 911.
Do not pass go. Call 911. Stuart has a question about the procedure. How long is the wire that runs through the arteries? So
we have different length wires, but most of them are, we go in centimeters, so 200 centimeters. So, you know, they can be, but we can use them, say they might be 3 or 4, occasionally they'll be 3-4 feet long. So it looks like a very long wire on the table. Yeah, exactly.
And it's just a wire and that's going.
It's tiny, it's not much bigger than a hair.
Oh,
they're really tiny and you can thread them down, find
and what's it made of so it doesn't bend on the way or hit?
So they used to be made very simply, like out of one material, so, you know, a type of you know, like almost any kind of wire. But now the Japanese have advanced this crazy amount. So now even a tiny wire the size of your hair can have multiple different components. So it's multiple different, and if you look at a cross section, it can be multiple braided types of wire and elements. So
and that tiny little.
And you can turn it and steer it and drive it where you need to.
So interesting. It's just fascinating. And I want to bring both Dr. Kennedy and Dr. Spaedy back in for some final thoughts as we start to wrap up this conversation. Dr. Kennedy, I want to talk to you about trusting your gut. You knew something was off?
So, yeah, you know, I teach the students to trust your spidey sense. You spend you know, your academic career as you go through medical school developing a sense of, you know, what's normal and what's not, and sometimes it's just the pursuit, not being dismissive, but let's pursue, you know, what the possibilities are. And I think it is. For me, certainly, it was that, you know, well, I didn't know what was wrong. I had maybe a general idea. It wasn't like my heart attack, but I also knew that it wasn't right. And, you know, what can we do to investigate this? And I think sometimes that can be really frustrating for my doctor team. Sometimes it can be really frustrating for the patient to kind of, methodically work through that whole process. Fortunately for me, everybody was marvelous, and they all listened. They took me seriously. They said, yeah, you're right, that this isn't what we would expect. Let's try to figure this out. And it was a series of tests that showed what the problem was, and then the answer was presented to me. Actually, right at first, it was, we don't know what else to do for you. And actually what's funny is I had my financial advisor meeting right after that, and we were talking about, well, what can I do to make sure that my wife has, what she needs for the rest of her life. And so it was right after that conversation then that I get another call from my cardiologist, Dr. Steve Owens, and he goes, you know what, I was talking to one of my colleagues and sharing this, and I think he might be able to help you.
Wow.
And so then we had a consultation with Dr. Spaedy. Of course, I probably made him a little nuts because I wanted to do a full risk-benefit analysis of this.
Oh.
That's all right. That's all right.
And
he spent the time.
And you brought someone back from the brink. I mean, you're sitting next to a man who's alive today because of something you did.
Yeah, well, I mean, definitely a lot of what we're doing is, helping quality of life, or trying to, that's our goal, is to make it so you can do what you want to do or enjoy the grandkids. So it's still, even after I've been doing this over 30 years, so it's still, you would think that would get rather not special anymore, but it's still special, so that's still a big driving part of the job.
We love sharing all the incredible work that our doctors do here. And something else we also love doing is showing you what life looks like for our doctors outside of these hospital walls.
Now for a secret look into the guardians of healthcare at the University of Kansas Health System. Let's go behind the mask.
All right, Dr. Spaedy, we're going behind the mask and talk about living life to its fullest. Who is this sweet little creature?
Hey, so that's our first grandkid. So I've just got a couple. I'm a little behind Dr. Kennedy, but we've become pretty good buddies. That's Jackson.
And I know you read Dr. Seuss in the beginning. Is that you and him with the medical journal?
That is actually, nowadays they love the phone. He's always like, turn on some kitty cats or show me an elephant on the phone. So he likes little videos. So.
And then what's this? It's warning, danger, do not go beyond.
Hey,
what are you doing there?
I love to bike ride. So this is one of my best friends, and we rode the Katy Trail this weekend and went over the Missouri River, and there in Boonville, there's a bridge that's closed down, but it's got concrete way out in the middle of the river, so you can go right up, but then there's a big sign, don't go any further.
Did you go any further?
We didn't go any further.
Okay, good. We just want to hear that you stopped right there. Thank you so much. Huge thank you for sharing your family with us and your journey. And Dr. Kennedy, thank you for sharing your journey with us. It's going to help so many people, and it's amazing to see you here.
Well, that's the reason I'm doing this, right? It's, when you guys asked me to do this, it's a little bit embarrassing but humbling, and it's hard not to be emotional. But on the other hand, I think it's critically important that people need to know that there are options. And so that's what I wanted to be sure, that the message got out, that that procedures like this, people like this are available. So
it's a great message. Message received. And thank you so much for being with us today for this conversation. Coming up next week on All Things Heart, there is a strong connection between smoking and heart disease, even if you're not the one holding the cigarette. We see firsthand the generational struggle of tackling this addiction, the damage to your heart every time you light up, along with the resources on how you can quit. Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update, Jim Dayton's symptoms started as a stuffy nose. When his arms started swelling, he realized he needed more than a decongestant. I'm Jessica Lovell on the next Morning Medical Update, the sneaky signs of non-Hodgkin's lymphoma and the urgency that started Jim's treatment and helped save his life. Friday at 8.